Welcome back to the morning show here on Arise News. According to the World Health Organization, breast cancer is the most frequent cancer among women, impacting 2.1 million women each year. It also causes the great number of cancer-related deaths among women. In 2018, it's estimated that 627,000 women died from breast cancer, an estimate of 15% of all cancer deaths among women. Joining us now to speak on his clinical study on the treatment of breast cancer in Nigeria is Dr. Adekunle Osin. Good morning and welcome to the show.
Good morning. Sir. Thank you for joining us.
I'm really happy to be here.
Thank you. So I want to start with just helping people at home understand breast cancer. Everyone hears breast cancer. Everyone understands breast cancer. You hear of people that have mastectomies, double mastectomies. There's so much information, but also at the same time, there's so much misinformation around breast cancer. Can you just sort of contextualize breast cancer and how the rates of infection in Nigeria?
Yeah, again, thanks so much for having me today. Breast cancer, there's been a lot of misconception about breast cancer. And I'll share something with you. The first case of breast cancer I saw when I was a house officer at UCH, Ibadan, was actually in a man, which would be very strange now. And I remember those days, the sort of treatment was so painful for the person, for the patient, for the doctor. And a lot of factors, especially in Nigeria, are attributed to the late delay in identifying breast cancers. Most people will rather go to the spiritualist, go to the herbalist. They will assume it's a spiritual attack or it's witches and wizards. Now, all over the world right now, breast cancer is considered not
fatal.
A lost, not a lost cause anymore. In the US, I actually have a friend, an older friend, who has survived breast cancer for 50 years. And it's all because early diagnosis, treatment, follow-up, and being persistent that this will not kill me. Now, we also found out, and I'm going to reference some people who have done a lot of study, a lot of work preceding this clinical study. One of them is Professor Funmi Olopade,
yes.
a friend of mine, a classmate of mine, and her husband, Professor Shola Olopade. We were all both at, in Chicago. She especially had worked so much on identifying the fact that breast cancers in African American are more aggressive than in whites. That's number one. Breast cancers in Nigerians are even more aggressive than African American. Now, if you take that and add to the fact that there's delay in identifying it in Nigeria, then it becomes even much worse. So I hope we'll have time today because I want to share another thing about breast cancer awareness, which I will challenge the government. I know how much you spend on elections. I have someone who has produced breast cancer awareness DVDs that will cost the populace maybe about $2,000 to $3,000. This is something the government can subsidize. Because if you know how to examine your breast and pick up on time, this sort of treatment we're bringing in for this clinical study will be virtually a cure if you have the type of breast cancer we're going to be treating.
So tell us about what brings you to Nigeria from America now in this study.
Okay, well, my passion, I want to give back. And honestly speaking, another problem with Nigerians is we don't want to own up. I've had breast cancer hit home, very close to me, family members who have had breast cancers. And growing up, we are taught to always give back. And this is a form of giving back. I don't like saying this, but the truth is I'm doing this for free, at least on my own part. My colleagues are doing it also virtually for free because we've worked so hard to, one, convince Roche, one of the big pharmaceutical companies, to supply these drugs worth millions to each of the patients. I've been told not to give the exact figures, but it's millions to each of the patients.
Oh, wow.
Yes, and they're also working in conjunction with the University of Chicago. They'll be providing other drugs, other test materials. So each of these patients that will enroll on these studies will virtually be having free treatment for breast cancer.
So you're providing free treatment for breast cancer
Literally
to
free.
patients in Nigeria?
Yes.
Where in Nigeria?
Right now, because we've got to start small.
Sure.
Okay, the other problem is over the years, we've been trying to bring research into Nigeria.
Yeah.
Now, this is a digression, but it's important, especially to our government. Now, for example, in Russia, you cannot sell any drugs without having tested it in Russia. Why? Simple thing. If they test your urine in the US, if you didn't tell them you are white or black, or your renal function, they might completely give you wrong medications because the test in white is completely different from that in blacks. So the reactions to drugs that have been approved in the US might really be different from those in Nigerian patients. And so if you don't bring in testing, clinical studies into Nigeria, then we will not really test it in our populace. And then we'll buy drugs that will work wonderfully well in the US or elsewhere and will not work here. Or otherwise, we'll have side effects that will not be seen in the whites. Now,
one of the things that I was reading about when I knew you were coming was actually the way drugs metabolize, which is sort of what you're talking about here.
Yes.
The way that black people, black women, white women metabolize drugs is different.
Yes.
Tell us how that could affect someone that's taking a drug that's approved in a place like, most of the drugs used for cancer treatment in Nigeria are not tested here. The way drugs are metabolized in the system, how can that, what type of effects can that have on the system?
First thing is, again, going back to the renal function, the kidney functions. Now, because the way our kidneys clear toxins or waste is different from the way it's done by the white, it means any medication you use the level in your blood as a black man or black woman could be much higher than the level in the blood of the white person. And which means if it was tested only in whites, you will have more accumulation of toxins, and then it will harm you. And even if it's effective, you have more of the harmful side effect. The other thing, of course, is it could be excreted even faster in you, which means you will not have as much effectiveness as it will be in the whites.
So it's really important for the drugs to be tailored to the race and ethnicity.
Absolutely.
But let's go back to the triple negative cancers and this treatment. Are you impressed I learned the term?
Oh, yes, thank you so much.
I had to learn the proper term, sir.
Yes.
So, and this treatment that you're bringing in, let's talk about that. What is the rate of survival? How long does it take for the treatment to start to work, to see improvement, for the tumors to start to shrink? Side effects, how manageable they are? Let's discuss that.
Thank you so much. Again, that's a really very good thing to discuss. But just before that, I want to tell you how come about the triple negative or triple positive. It's called the HER-2. It's some of the cancer cells that secretes or that makes that particular antigen are the most aggressive cancer cells you can find, and they are more in the blacks, African American and Nigerians. And studies have shown that in African American, it's totally like a cure. We don't want to use that just literally in cancer treatment.
Sure.
But I can tell you that it's totally like a cure. In those days, just a few years ago, life expectancy for cancer patients were measured in 5 years, the 5-year survival rate. Sure. Again, I've told you, I know somebody for 50 years that has been free. This, when it's given, it's expected within 6 to 12, 24 months, some of them will have complete shrink rate. In but some of them will have what is called complete remission physically. And some, after that, even if they now go in for a mastectomy, they must still find complete pathological remission. But the key word, and this is the operative word, you need to have to be tested. There's something, a test called immunochemistry testing, which again, I want to appreciate, especially my friends, the Lokwadis. They brought in the histochemistry testing into UCH many years ago, and we have it at Lut now. That would confirm if you have the HR2 positive antigen. And if you have that, you will qualify for this study. Again, please note, we are starting from a first step.
Sure.
Okay. Now, our execution of this study, and this is where I come in, our execution of this study properly, such a way that we can present data that can be accepted by international regulatory bodies, would enable us to bring in more studies, more of this sort of drugs, more even for hypertension, for diabetes, for everything into Nigeria.
That's fantastic.
That's exciting. That's exciting. The triple negative, is it also found in white women as well?
It is.
Okay, but at a lower rate?
Yes, and no, we are actually triple. Sorry, it's triple positive that we're talking about.
Triple positive, okay.
Yes, triple positive. The triple positive is even much more aggressive than two positives. But again, key thing about accepting research as a way of life is making sure that we can find drug combinations that will target each of those things. Now,
we're going to go on a break. I'm going to ask you to hold that thought. And when we come back, I want to talk about early diagnosis and the opportunities that we have there that we might be missing. Welcome back to the morning show. We're still in studio with our breast cancer expert who is also conducting some clinical research in Nigeria, Dr. Adekunle Osin. Before we went on break, we were talking about different types of breast cancers, the rate of occurrence, and this treatment that you're going to be providing. But I want to take a couple of steps back to actually talk about prevention, but really early detection before we talk about prevention. And what is the benefit of early detection?
Oh, well, the benefits are enormous because the earlier you pick it, the better. I think it's Angelina Jolie.
She was tested for the BRCA.
Yes, and she's the face of breast cancer rather in the whole world. And she decided, oh, yeah, I'll just go for the mastectomy. Okay, a lot of people will think that's drastic. But the point is, if you can identify, detect it early, there are so many things you could do to be cancer-free and live your normal life.
So I have a question for you. I was listening to a story last week. Another famous American comedian, she's a famous American comedian, Wanda Sykes. She said that she was going in for a breast reduction. And then I guess the pathologist test came back that there are some cancerous tissues. But because she was going in for something else, they couldn't really say exactly where. So she decided to get a double mastectomy. And the interviewer was asking her, did she not think that was drastic? And she said because she had a family history of breast cancer, she decided to do this. When you hear that about a patient, do you think, is that a right decision to make? Or what do you say to people is that drastic?
While the decision is personal to each patient, if you ask me, if I were the patient, I would do the same thing.
Really?
Yeah, but I mean, we cannot say because I could do it,
sure,
or somebody did it, you must do it. But the other thing you could do is ensure you examine yourself regularly, fairly regularly. Go regularly once a year to a doctor and have yourself examined.
As part of your gynecological checkup?
Yes. Make sure it's done. And, but there are DVDs that has been created in multiple languages in Nigeria, which so happens to be done by my nephew, but he was doing it independently of me or of any of the thing we're bringing in here. It just so happened I stumbled on it, and I checked the DVD. It's wonderful. It's used in many other countries. And what that does is at least you examine yourself, you feel a lump. Not all lumps that you feel will be breast cancer. That's, you've got to know that. Then number two, you have to be courageous. That you see something wrong, you've got to seek help. Now, again, it's not going to cost so much to set up even breast cancer screening stations in our hospitals, just to see if somebody has. And the earlier you get it, the better the chances of survival.
And I also want to talk about the fact that aggressive breast cancers are affecting women under 40.
Yes.
The general perception was always, oh, breast cancer is something for the elderly and you don't need to check until you're in your 50s. Yes. Just can you discuss that a bit?
Yeah, thank you very much. Again, that's one of the misconceptions. Actually, it's not only for breast cancer, it's for many other diseases, many other cancer studies. Cancers in the body. More and more, we're beginning to see even at lower ages. I'll tell you what, right now in Nigeria, our government might be thinking that we still have so much infectious diseases, communicable diseases, malaria. Right now, in the developed world, they're seeing much more of cancer of different forms than all those things. And it's coming to Nigeria because we're getting better now at treating infectious diseases. And then you're going to start seeing even more at early ages. For example, it's mandated in the US that once you are 40, you have to do
a mammogram.
Apart from mammogram, colonoscopy.
Oh.
That is another thing that kills so many people.
Yes.
And even at 40, they're seeing patients below 40. And at 40, they're going to start handing you, every time you go for a physical, you are 40 years old, have you done your colonoscopy?
And those are some of the ways they detect colon cancer.
Oh yes, that's the easiest way to do that.
So one of the things is there's a lot of discussions around mammograms. So I got my first one when I was 40 because that's what they said. Actually, I got my first one when I was 35 because I had found a lump earlier, which the lump was non-cancerous. And so after that, I had to continue to get them every so many years. I think it was 2 years, now it's gone to 5 years because the technology has improved and they can see a lot more. In places like Nigeria where people might not be able to go every so often, what is the recommended age to start getting mammograms and frequency?
Before the mammogram, please examine yourself.
So self-examination.
Yes, that is it. I would recommend going at 35. Because the point is, you've seen patients having breast cancer around 35, so why don't we go there? Now, of course, the cost will be something. But if you go back to examine yourself and you see any lump, then you know that whether you're 35 or 30 or 20, you would need to go. I had a friend who, long ago, in medical school, found out that she had a lump. And then she was in her 20s, but it wasn't cancer, but at least she found out.
That awareness just needs to be there.
Yes.
Let's also talk about cervical cancer. That's another big killer of African women.
Again, the key prevention for that is having examination done. Unfortunately, you can't do self-examination.
No.
But then pap smear.
From what age?
Now, breast cancer is supposed to be linked also. Cervical cancer is also supposed to be linked with infection, HIPV.
Yes.
And so because more people are contacting that even much earlier, if you have me to recommend, I would say at least by 30 you must start checking.
What's the frequency of the pap smear?
Every 2 years.
Yeah, every 2 years.
So it used to be every year,
Yeah.
but in the last 3 years, the recommendation has now come out that every 2 years.
Every 2 years, yes.
So every 2 years, you still have to get a annual checkup.
Oh, yes.
But every 2 years, you insist your doctor does a pap smear. It's there's a lot you have to keep on, you have to keep track of as a woman on these calendars. But I wanted to ask you a question. One of the things I was reading, that, which, you know, sometimes these are urban myths, but I'd love to hear from you, which is that there are certain products that Black women use that tend to also increase the level of toxins in our body that can cause some of these cancers or accelerated. One of them is skin lightening cream. One of them is relaxers, acrylic nails, especially the people that actually administer it. So they were saying that a lot of minority women actually do these acrylic nails, and therefore they are inhaling a lot of it, and also Brazilian blowouts. Have you heard anything about this, and what's your take on this?
Okay. It's difficult to just throw it out there, but maybe because of my interest in research.
Sure, there are no clinical studies around these.
That's the problem.
True. I know you're.
That
I know
people
you're.
don't.
Yes.
Yeah, people. The mistake people make is that even when you're applying that, there's nothing stopping you or stopping somebody or stopping the government from mandating somebody to carry out a research study to find out if the fumes or if any of those things can actually go into your body. And there are many ways that it can be designed. But the first thing we have to do, because before we go, I want to talk of NAFDAC regulatory authority.
Yes.
In this country, I'm going to take a cue from the last speaker. Women are very, very important to every nation. The first woman director, head of the FDA in the U.S., saved the U.S. from the thalidomide incidents in the 60s. Let me just quickly tell you about thalidomide. Thalidomide was a drug that was approved in Europe. And then they were going to bring it to the U.S. They said it was fantastic. And there comes the first woman head of FDA. And he says, she's sorry, you can't bring it into the U.S., even though we can see all your results in Europe, until we test it. And while they were going back and forth, they discovered that most women on thalidomide started having babies that were deformed in Europe. Go back and check it. That was one of the worst cases.
I know about this. Yeah. A lot of deformed babies.
Yes. So you cannot lose anything by establishing guidelines and research. There are many things NAFDAC still needs to put in place. They need to take charge. In the US now, the thinking even is you cannot, they're now trying to mandate people bringing in generics. You know, generics as anybody could make generics.
Yeah,
okay.
to the brand name.
Yes, they're now having them do tests, do clinical studies before they can be used.
Well, thank you so much, Doc, for really coming in and helping us understand the importance around this. But one of the things I want you to help people, for people that might not be able to have access to this DVD, what are some of the other ways that people can learn, or how can each one teach one when it comes to self-examination?
That is a challenge, but it can easily be, because it needs to be demonstrated.
Yes.
So women can have, or hospitals can have sessions that will demonstrate self-examination. And then each woman, if you can't get it right, have a colleague examine you regularly.
And we also need, from a behavioral change, it needs to be something that moms teach their daughters.
Absolutely, thank you.
The
Yes.
same way we have all these tips. But I wanted to just talk very quickly, where can people who want to participate in the trial, where do they go?
Yes.
In 10 seconds. Sir.
Thank you. LASUTH, UCH, and University of OAU.
Okay.
Ife.
Thank you, sir.
Thank you so much for being with us today.